you have any other announcements?
Other than it's good to see many of you here, new faces, and waiting for more people to join us. So I don't know what we should do. Maybe we should get started then.
Yeah, well, you want to introduce the doctor?
Well, I was going to ask if before we start anything, is if you would like to say the prayer, Khadijah.
Yes, I can.
We'll do the Pledge of Allegiance to get it started. Hold on. I have the flag.
Good.
Okay. I pledge allegiance to the flag
To
of
the
the
flag
United States of
States
America
of America,
and
and
to the republic
which
which
stands
one
one
nation
nation
under God,
under God,
indivisible,
indivisible,
with
with
liberty
liberty
and justice for all.
Thank you.
Thank you. Khadijah, prayer.
Yes, thank you. If everyone could just take a moment of silence. Dear God in heaven, we are so grateful and thank you for the opportunity for us to gather in your name, for all of these different clubs and different individuals who have a passion to do your work. We just ask you, Lord, that you continue to give us strength because we're dealing with such trying times now that can try to keep us off focus. But as long as we keep coming to you and asking you for direction, I know that we will succeed. Amen.
Amen. Thank you. Thank you. I would like to mention that the pandemic has disrupted the entire world. And there are so many organizations out there who are finding a cure or a solution to the COVID. And I just saw yesterday where the University of Pittsburgh announced well, it was a video, a short video. It was on the news in Pittsburgh, and it is supposed to, it's so small that it could actually enter where the virus cell is and destroy it and prevent the individual who has the virus from getting sick anymore and spreading the virus. Now that's in the research stage of it. And there are so many other avenues to finding a solution. And we're blessed here in Dayton, Ohio, to have someone who can save, who has found a solution to save lives for Blacks and people of color that I just can't help but feel excitement for Dr. Ron Fletcher. Now, I'll give you a brief introduction of him because there's so many things that he's accomplished in his career. I think he's been an oncologist for 20 years. He's an MD. He's done research on AIDS, and he's done research, and he's currently releasing his paper on the research on COVID. And he was the state health director for Ohio. So I'm going to turn it over to Dr. Ron Fletcher and take it from here. And we're being recorded, so if anybody misses this, I'll have access to the link and provide it to everybody. Thank you.
Well, good morning, everyone. I appreciate you being here. This morning, I want to focus on therapies for the virus. Now, there are two ways we can approach this. Certainly, we've all heard about vaccines, and the vaccine is a method in which we can prevent people from contracting the disease. But then there's another way, and that's once a person has the disease, a therapy that can eradicate the disease and make the patient heal and better. Unfortunately, vaccines are very difficult to make, and it takes quite some time. I know there have been comments about the vaccine being ready in 4 to 6 weeks, I just don't see it. Vaccines have to go through some very difficult processes to prove that they're safe, because remember, a vaccine is going to be given to the general population, to millions, billions of people. And if there's a side effect, that side effect can affect so many people. The recent information about the AstraZeneca drug causing something called transverse myelitis, and that's no minor symptom. Transverse myelitis is an inflammation of the spinal cord. And so from the level of inflammation below, that patient can have pain, they can have numbness, they can have motor difficulty, so they can't move. So it's a fairly significant difficulty. Vaccines take quite a bit of time to develop, and their ability to become FDA approved takes so much time. Once it's approved, then the facility to manufacture the vaccine has to be approved. Then the method of manufacturing the vaccine has to be improved. Then there has to be enough vaccine manufactured to cover the population, and all of that takes time. So even if a vaccine was developed in the next, let's say, month, it would still take months before we could actually get it out to people. So with that being said, then I think our best chance of having a major impact on the mortality and serious morbidity of this disease is to develop an effective therapy. Now, let's start by looking at the fact that, so, we call this now SARS-2. So I guess the big question is, so what was SARS-1? Well, SARS-1 was a pandemic also, and it was noted between 2002 and 2003. The difference between SARS-1 and SARS-2, they're both coronaviruses, so they're both in the same family of viruses. The difference between SARS-1 and SARS-2 is that SARS-1 was much more deadly than SARS-2, but SARS-1 was less transmittable. We hear about SARS-2 in which people can be asymptomatic and transmit the disease. That wasn't the case with SARS-1. So kind of gave you a warning. If you saw someone who was obviously sick, you can obviously stay away from them. And that's one of the reasons why we were able to control that disorder. We never found an effective treatment nor an effective vaccine for SARS-1. But through public health means, by walking through the methods of prevention and by having groups like the Canadian Epidemiological Society taking a look and tracking the disease very carefully, it essentially disappeared, died out. Now, again, SARS-2 is different. It's not as deadly, but it is indeed deadly. And the other point is that it can be transmitted without the individual who's infected even knowing it, which means no one can know it. So let's talk about how viruses work, first of all. And how viruses work is important because it gives us targets as to how we can attack this, how we can develop a therapy to attack it at certain points. So viruses have this tendency to bind to normal human cells. And with SARS-2, those little prickly points, those little pinpoints that pop out of the virus, those are contact points, receptors that can bind to human cells and allow it to penetrate into that cell. Once the virus is in the cell, it causes the cell to help it replicate, to make more copies of itself. After that's done, the virus either waits until the cell dies or the cell explodes simply from the volume of virus that is being replicated, and then it's released into the system and it's able to attack more cells. So those are the methods. The principal area that we've been looking at as far as treatment is concerned is to look at that factor in which the virus binds to those receptors on the surface of the cell and enters into human cells to cause it to replicate. And there are a number of therapies that have been noted. Now, I want to go over first some of the therapies that we've heard about, perhaps mention a couple that may be of surprise to you, and then talk about my research that shows a very practical, very cost-effective, very doable and attainable goal to help rid people and prevent them from having serious complications and mortality associated with COVID. So let's talk about covalent plasma. Now, it was touted by the NIH before the Republican convention, and I was kind of concerned about that because 2 days before that announcement, the researchers that were looking at COVID, that were looking at covalent convalescent plasma had mentioned that they had not found significant clinical improvements, and they did not see any significant reduction in death. When it was announced, they were talking about these huge 35% or more reductions in death. And the data just doesn't support that. Remember, data can be massaged, and it just depends on how you approach it. You can make numbers say whatever you want, but in science, we try to make numbers say what they actually mean. So covalent plasma is basically taking plasma from individuals who have had the infection and have resolved the infection. And their plasma would have antibodies that help them fight off the disorder. And these antibodies have been primed to recognize this disorder because they've been exposed to it. And so by giving transfusions of that blood, you're putting these antibodies into that infected individual, and those antibodies are killing off the virus. So that's one method. Now, antibodies are produced by a certain type of white cell, and that's called a B cell. B cell produces immunoglobulins, and immunoglobulins are kind of like the Lucretia Borgias of the cell system. They produce this immunoglobulin, which essentially kills and helps the immune system destroy the virus. There's another cell called T cells, and those are kind of the Mike Tysons of therapy. T cells slug it out directly with the viral cells and kill them in that fashion. Convalescent plasma focuses in more on the B cell phenomena. So convalescent plasma has been given emergency approval, and so those physicians who feel that it might be beneficial for their patients can receive it, even though it has not gotten official FDA approval. There are also a number of antiviral drugs that essentially have targeted specific types of the life cycle, as I mentioned before. The difficulty is that the effects of some of these medications, the doses of some of these medications, have a very negative point, and that is sometimes they kill the individual or kill the human cells along with the viral cells, and we have to certainly avoid that. The other thing that viruses can adapt to what's going on and what's being used to defeat them, and that adaptation is associated with mutations. SARS-2 mutates at a very fast rate, and so it's easy for it over a period of time to sense what is being used to defeat it and mutate in a fashion so that it can survive and the medication is no longer effective. So resistance to the medications develops. And that's one of the setbacks to trying to find and why it takes longer to try to find a therapy. Some of the more common things that have been used, one is dexamethasone. It's a steroid. It's been around for decades, and it is an anti-inflammatory drug. Viruses and what they do cause inflammation. And inflammation such as lung tissue, which can cause some serious immune responses that cause death. One of the things that we hear a lot about is something called Cytochrome Storm. And Cytochrome Storm is where the virus has stimulated so much inflammation that the immune system just sort of goes a little overboard. It produces so much of a resistance that that resistance begins to attack the normal cells. And that is one of the principal reasons people die from COVID-19. But dexamethasone can subdue that inflammation and therefore help reduce the death associated with that. But there are certain problems. For instance, we don't really know when to start the dexamethasone. Do we start it immediately? Do we wait until someone requires respiratory assistance? We haven't really perfected that. But at this point, dexamethasone seems to be a very effective part of the therapy for COVID-19. Speaking of anti-inflammatories, we all probably are aware of the Motrins, the naproxens, those non-steroidal anti-inflammatory drugs. They have also been suggested as part of the therapy for COVID-19. Although initially, French investigators were looking at it, and you probably heard if your little one has a flu or a bad fever, don't give them NSAIDs because it may make things worse. Well, there was some controversy as to that being the case with regard to COVID-19. So initially, it was said if you're having aches and pains, those types of flu-like symptoms with COVID-19, don't use NSAIDs, use acetaminophen, Tylenol. But since that time, there's been some modifications on the thought, and so it's felt that if for some reason you're taking too much of the NSAIDs, and NSAIDs can cause difficulties, such as irritation of the stomach lining and causing irritations and causing ulcerations. So if you're taking too much or if you can't tolerate it, then you can certainly go ahead with the NSAIDs. So let's see. So again, NSAIDs, the other thing is they're easy to get because they're everywhere and they're over the counter. Initially, the French and Chinese scientists had been looking at an antiparasitic, a medication that was used to treat malaria, and that was called chloroquine or hydrochloroquine. Some of the early studies showed that it had some effect, and when you added an antibiotic, azithromycin, which is a common drug that we use to treat strep throats, that combination seemed to be very, very effective. But in further evaluation, it was found that it just didn't bear out. It seemed to cause more difficulties because hydroxychloroquine can cause blindness, it can cause heart difficulties, it can cause a number of problems. And so when you take a look at the risk and balance it with the benefits, the risk outweighed the benefits. And so it's now being said that that's not an effective therapy and should not be used. We do a lot of studies, and our first line of studies is to look at this in vitro in the lab on the Petri dish and try to find out what's working. The problem is that doing in vitro studies, doing studies with animal models, don't necessarily translate to effectiveness in live humans. And so we have to do a lot of research, and that's generally with regard to clinical trials. And clinical trials are the mainstay of the scientific process. I remember a time when, during the Spanish-American War, when people were dying of malaria, and the pervasive attitude at that time was, well, you have all these malarial parasites in the system, so why don't we bleed the patient, have him release blood, and therefore he's releasing parasites. Unfortunately, that didn't work, and a lot of people bled to death, but no one essentially had an effective therapy. But they did that because they didn't use the scientific method. They gave someone, they bled someone, and that someone became better, and so they assumed that everyone becomes better. However, I can tell you, if you give 1,000 people a glass of ice water, someone's going to get better. And it's not because of the ice water, it's because they just had the ability to resist that. So scientific method is test and study. And the highest degree of test and study is to use a randomized, placebo-controlled study. That means you don't pick and choose individuals to try to skew your data to be more positive. You take a look at a general population and you just arbitrarily say, you're going to get the medicine, you're going to get the placebo. The placebo being just something that essentially has no efficacy, like a sugar pill. When you do those studies, then you have the greatest ability to accurately determine how effective the medication is and how safe the medication is. Another one of the antiviral drugs that we've heard a lot about is a medication called remdesivir. In the lab, remdesivir seemed to show that it really helped to prevent the reproduction and spread of the virus, again, in the lab. But then they started doing human studies and they saw that it was effective in human patients. The difficulty with remdesivir is its clinical benefit is not as great as it has been touted. Probably what happens is without remdesivir, people will have a 15-day course of the disease. With remdesivir, people may only have an 11-day course of the disease. So not really a big difference. And the other problem is it does not seem to show any decrease in the number of deaths. So it's less effective in sicker patients. And that's one of its difficulties, one of its shortcomings. But again, it's also something that has emergency approval to be used. Hydrochloroquine was an antiparasitic. And so we've been looking at other types of antiparasitics. And one of them is called ivermectin. And that's been getting a lot of information, a lot of play in the media. Ivermectin is an antiparasitic that is used to treat roundworms, strongyloides, follicularis, multiple types of roundworms. But it is an antiparasitic. And the feeling was, well, if one antiparasitic shows promise, maybe others will do the same. And so we have looked at the ivermectin. The initial studies showed that it was extremely effective in destroying the virus. But then they started looking at doses. And it appeared initially that in order to get a dose high enough to cause a response that actually killed the virus, that was incompatible with being able to take it as a human. So the dose range would be lethal. And therefore, in order to kill the virus, you'd have to kill the patient. They've made some modifications and they've been able to take a second look at that. And so it's being studied even more so because it now appears that it's probably or possibly something that can be utilized. There's also monoclonal antibodies, and Tony mentioned the antibody that has been discovered at Pittsburgh, and there are numerous of these antibodies that are being evaluated at this time. Now, when we evaluate, the FDA requires certain steps to go through. There's phase 1, and phase 1 essentially just kind of seeing if it's effective. Phase 2 is looking at whether it's safe. And phase 3 is looking at a large number of individuals to try to see how effective it is and how safe it is. But then there can also be a stage 4, which is further studies after the FDA has approved the drug. And again, remember, even after it's gone through those steps, there still has to be FDA approval of where it's manufactured and how it's manufactured. So a number of steps. So there are numerous monoclonal antibodies that are being evaluated at this time. They're basically, most of them are in phase 2. So just that safety evaluation. There is also a type of therapy that's being looked at by Regeneron, and it's being tested. But what Regeneron feels is that this medication in itself is probably not going to be effective, but when used with remdesivir, it improves that outcome with remdesivir. And it's my opinion that combination therapy is going to be the effective method of treating COVID-19. In oncology, we found out that at first we discovered medicines that had some effectiveness. Then we found medicines that had more effectiveness, but then we thought, well, if one medicine works pretty good, what would happen if we put together 2 or 3 of those medicines? In other words, to develop a combination therapy. And from that, we started finding excellent therapy and actually cures of disease. So the other factor is that the same thing happened with regard to HIV. One medicine was effective, but then when they combined multiple medications, they found that it could eventually stop the progression of the disorder. So combination therapy, I think, is going to be the thing that is going to be the future of therapy. There are other more common medications that have been used to treat COVID, and one of them is heparin, the blood thinning agent. And it seems to have an effect by blocking how the virus binds to those cells so that it can get into the cell. So heparin is something that's been around for decades. It's very common. It's very accessible. And so it shows a potential to being part of the therapeutic combination for the treatment of COVID. One of the drugs that as I was looking, one of the drugs that I was kind of surprised to find was if you have had little kids who have taken the wrong thing or what have you, there's a product called serum of ipecac, and it causes you to vomit, to get everything out of your system. Well, in looking at this, we found out that it can also stop the replication of the viruses. And so the company that works with ipecac has actually made an IV form of the drug. They're doing studies for this at this time. So again, as far as those therapies, there are numerous types that are being looked at. There is promise in a number of them, but their phase of study for improvement is early and it's going to take time. I would say a therapy is going to take less time than a vaccine, but for both of those potentials, it's going to take time. So the question is, what can we do in the meantime? Is there something that we can utilize to help us at this time? And that's what my research has been looking at. There is a product called vitamin D. It's in every grocery, every drugstore shelf. It's pretty inexpensive, but we have found that vitamin D has this potential. Vitamin D is actually not a vitamin, it's actually a hormone, because vitamins are essentially essential nutrients that you get from food. Vitamin D isn't really found to that degree in food. Certainly there's some in salmon, and they try to fortify milk and things of that sort, but that's not quite the way of doing it. Vitamin D is often called the sunshine vitamin because vitamin D occurs when the sun is exposed to skin, the skin absorbs it, works on cholesterol, and then through a metabolic process through the liver and then through the kidney produces an active form of vitamin D. Initially, we felt that vitamin D modulated the bone, calcium production. And so we were very happy to see that. And so people that have difficulties with low calcium levels, difficulty with the bone density, vitamin D was very important. But since that time, we've learned that vitamin D has so many more beneficial aspects to it. Vitamin D actually turns on the human immune system. And the human immune system that it focuses on is it stimulates the production of T cells. Remember, I talked to you earlier about B cells and T cells. And when they were doing the talks and the research on convalescent plasma, I was kind of disappointed because vitamin D doesn't impact B cells, it impacts T cells. But since the data on convalescent serum has been lackluster, the thought now is that it is the T cell that has more of an activity in preventing and taking care of suppressing that disease. Therefore, vitamin D, again, is very important in that role. Now, not only does vitamin D stimulate the immune system and the T cell production, as well as helper cells, vitamin D also modulates the immune system so that it doesn't go too aggressive. Remember, we talked about Cytochrome Storm, which is when the immune system becomes extremely aggressive and starts to destroy and attack tissue. Vitamin D suppresses that, and it reduces the potential for Cytochrome Storm. And Cytochrome Storm is the greatest fatality cause for COVID-19. There have been a number of other aspects that we've seen with regard to what sort of difficulties and what sort of severity is caused by COVID-19. And I've traced all of those. So let's talk about, so we've talked about Cytochrome Storm, and we know that vitamin D helps to increase your immune system and helps to modulate and suppress Cytochrome Storm. But there's also something called a coagulopathy. In other words, an increase in the blood's capacity to clot. Now, the difficulty with this is that those clots can block arterial circulation and cause strokes and heart attacks. And in fact, we noticed that in a number of individuals, generally in their 40s and 50s, one of the major causes of death is stroke or heart attack because of that coagulopathy that's associated with the COVID-19 viral infection. I have been able to establish a link between vitamin D and its ability to suppress that coagulopathy. In other words, it reduces the potential that those coagulation difficulties, those clot formations will occur. There's another activity that's has been very common, and I was trying to find some relationship with this. One of the presenting symptoms of COVID-19 is a loss of smell and taste. And that is a very common warning sign that you have the disorder. It can be very, 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 very potent because without smell or taste, who wants to eat? It's like cardboard. Well, I have finally been able to find a link between vitamin D and taste and smell. And vitamin D has an important role in maintaining taste and smell. There are actually case reports of individuals who had vitamin D deficiencies, and because of those deficiencies, they developed taste and smell disorders. Now, we know that statistically at this time, African Americans, Latinos, people of color have a much higher, almost 3 times higher fatality rate than the white population. The reasons being, number one, we have found that in the United States, 42% of people that are white have vitamin D deficiencies. But we found that almost 80% of people of color have vitamin D deficiencies. One of those reasons is that, remember I said it's the sunshine vitamin, and so the sun comes down, your skin absorbs it. People with darker pigmentation have less of an ability to absorb that sunshine, and therefore it makes them more potentially resistant to having vitamin D levels at normal range. The other thing is that African Americans, Latinos, probably have a greater potential of working in jobs that, for instance, don't allow them to social distance. So their immune system has to be far better. Not to mention that they probably have more of a potential to be working in environments that are closed and do not allow them to get adequate sunshine. Now, for most people, 15 minutes in the sun should be adequate to, on a daily basis, should be adequate to keep your vitamin D levels normal. But certainly having a supplement is even better. So we've been able to understand why the mortality rate is so much higher in African Americans, in Latinos, in people of color. Certainly there are social economic factors that are associated with it, but there's also a nutritional factor. The social economic factors can't be immediately taken care of. It's going to take time and money and planning and such, and it's not going to have an immediate fix. We can't wait that amount of time because the difficulty, the desperation is now. Vitamin D can help with that. I'm not saying that vitamin D cures. I'm not saying that vitamin D prevents. What I'm saying is that vitamin D, having an adequate amount of vitamin D, helps your immune system to work at its peak. And when it works at its peak, it improves the ability to fight off the disease. It improves the ability to subdue those complications such as clotting, such as taste and smell. And the other aspect is that vitamin D also has an important part with regard to mortality in general. We found that when we've taken a look at individuals that have vitamin D deficiencies versus those that do not, the people who have vitamin D deficiencies have a higher mortality rate when the groups are mixed. Vitamin D also, deficiencies also are associated with the onset of diabetes type 2. And there are a number of other disorders that have been associated with vitamin D deficiencies. So I'm trying to promote people need to make sure they have adequate vitamin D levels. I was surprised. In January, I went to my physician. He decided just arbitrarily check my vitamin D. It was low. And so I immediately got on megadose vitamin D to bump that level up. And in a short period of time, you can do that. Let's talk about vitamin D therapy. So if you have a normal vitamin D level, taking 1,000 to 2,000 international units a day should be sufficient to maintain that. Now, you don't want to overdose. You don't want to take too much because vitamin D is a fat-soluble vitamin, which means it can accumulate in fatty tissue in the tissues of the body. And too much of that can cause side effects. Most of the other vitamins that we take are water-soluble vitamins. And that's kind of made a little story internationally that guess what the most nutrition-rich substance in the world is? And the answer is the urine of Americans, because we take so many water-soluble vitamins that essentially we don't need, and so we excrete it through our urine. So again, vitamin D is so important with regard to the immune system, with regard to multiple other types of disorders. The great thing about having vitamin D play this role is, number one, it's readily available. Number two, it's inexpensive. Number three, it's in quantities that can be taken advantage of immediately. So everything's there to help people fight off the disorder. Because as I said, there's going to be a time period, a lull, between what we're doing now and when we come up with a therapy or a vaccine. So let's try to do whatever we can do to try to help ourselves to fight off this virus. Now, certainly vitamin D is enhanced with taking magnesium. Magnesium helps to release vitamins D. So having magnesium as another type of nutritional supplement is also important. To have a protein diet, a good protein diet is also important. All these factors go together. But vitamin D seems to be the principal agent that shows the most potential effect. So at this point, I want to kind of open things up for any questions anyone might have.
Ron, this is Glenn Costi, and great presentation. I just I wanted to share with the group that my wife and I both had the COVID disease in July, and we had very mild symptoms, thankfully. And then we now have tested positive for the antibody, so we're hoping to give blood and be able to help others with the antibody. A friend of mine who is the same age and the same health condition also got the disease at the same, we think we all got the disease at a pool party. And he had drastically different results. He was had high temperatures. He was eventually admitted to the ICU at Wright-Patterson Air Force Base and spent 10 days on a vent and has thankfully recovered from that and is at home now. But it's just fascinating to me that this disease has such drastically different paths depending on who's infected. I think that makes it harder for the medical community to manage, because you're getting just-in-time information on a particular patient, and then you've got to find a way to share it as quickly as possible. But just an interesting summer for us through this process, and you know, it's going to be with us for the foreseeable future. You know, I know the president talks a lot about sort of the pre-purchase that the federal government made for a vaccine to sort of take away the risk from all of the pharmaceutical companies on, you know, whether or not they can do it or not. So it looks like we're trying to do everything we can to speed things up, but still, like you're saying, Doctor, you know, the science has to be followed, and until the science is approvable, we don't want to release this on the community.
Right. One other thing I might mention, besides people of color, there are other groups that have a propensity for vitamin D deficiencies. 1, elderly people. 2, nursing home residents. 3, individuals that have other types of disorders such as diabetes, hypertension. And guess what groups have the highest rate of COVID mortality? Elderly, nursing home residents, those with morbidity factors. So it all kind of fits in with that sort of circumstance. The other thing you mentioned about are the different presentations. Again, we have individuals that have no symptoms. We have individuals that have severe life-threatening symptoms. And remember I mentioned that the virus can adapt? Well, it doesn't have to have a drug that forces it to adapt. It mutates simply because of its method of replication. And so we can't think of COVID-19 as being just one virus. It is a family of viruses. It's a family of mutations that start off with one activity. We now know that initially the COVID-19 type that came to our shores was a Chinese variety. But then later on, and the difficulties that occurred in New York were because that was a strain of COVID that came from Europe, and it was a different strain. It had a higher potential for transmission. So we have to remember that, again, that's also going to have difficulty with regard to therapies. So it makes it a lot more difficult. So you're right, we're going to have it for quite some time. This could turn into essentially seasonal disorders. So we may be able to suppress it to a certain amount of time, but come the fall and winter, it's going to return.
Ron Suinbill, does a high SPF sunscreen inhibit your ability to produce vitamin D?
Wow.
Right, right. Because again, just like pigmentation, it prevents the absorption of sunlight. And when you prevent the absorption of sunlight, the body can't metabolize into an active form of vitamin D.
Wow. How about in the wintertime when the sun is less strong?
A very good point. What we also know is that people that live in northern climates have a tendency to have less vitamin D deficiencies, and that's because they don't have the sun exposure. Unfortunately, we live in one of those areas. And so it has been found that people that live in those areas have a greater number of cases of vitamin D, and because we're going into a time of year in which we have less sun exposure, those northern climates, those northern countries are probably going to have another phase, another chapter in which this virus will increase because they won't be able to absorb vitamin D. Remember, I mentioned that it has to be the sun because foods have minimal amounts. We only get 10 to 20% of vitamin D from foods. The majority, the overwhelming majority, comes from sun exposure.
What about those lights that the people use in the wintertime? Those,
you know, I would say that that probably has some effect, but it depends on the light. You know, there are various types of light. There is the lights are caused by certain types of materials that are used, helium, hydrogen, a lot. There are certain types that more duplicate the sun, and I would imagine they might have some effect, but unless you know how much that particular light source mimics the sun, for instance, the lights that we have in our house, they don't mimic the sun. These are the ones that demonstrate the sun are like high pressure sodium lights, and those are as close to the sun as possible. But unless you live in a football stadium, then you aren't going to be exposed to that.
Someone asked the question, I believe it was Kadisha on chats. I think she wanted to know which is better vitamin method of taking, either a liquid form or a tablet form.
Doesn't really make any difference. Both are absorbed fairly well. Now, there are different types of vitamin D that you find in the drugstore. There's a D2 and then there's a D3. The D3 has been compared to the D2, and it appears that D3 has a longer activity life than D2. So in choosing which type of vitamin D, it would be a product that contains vitamin D3.
Thank you. People on blood thinners, what's their chances of survival from COVID regarding the blood clotting?
Well, again, being on blood thinners is advantageous because that helps reduce the chance of your developing clots. And so that certainly would be helpful. Problem is, being on heparin requires a certain diagnosis, and that generally is not the case. Most people are taking blood thinners like Coumadin, oral medications that they take at home, Plavix, things of that sort. Heparin is an IV solution, or it can also be given subcutaneously, but it has to be injected.
Okay, Dr. Fletcher, from a prevention point, you know, because, you know, I shared with you earlier, I run sober homes. We take everybody's temperature every morning. We sanitize the conditions of the house, the doorknobs, you know, try to keep distancing, keep the mask on, you know, those types of things. But we're dealing with individuals that are walking around that are carriers that do not have symptoms. And that's a major concern, you know, especially at the house, because our clients go out to AA meetings, NA meetings. They're meeting with other family members during visitation. And if they're around somebody who does not have the symptoms, but they catch it, what can we do? You know, I'm just trying to figure out what more can we do from a prevention. Is there anything else that you could offer information is from a prevention? Because right now, I can knock on wood and say we've been successful so far. Nobody has come down with anything serious as of yet. For a while there, everybody seemed to have colds, they seemed to have fevers, but they were just the regular run-of-the-mill viruses and colds. And it was not COVID by the grace of God. But I'm just trying to figure out, is there anything more I could do from a prevention level?
Well, again, you know, taking temperatures is certainly a help. But remember, asymptomatic people don't have symptoms. They don't necessarily have to have temperatures. And so
Yeah.
someone that has a normal temperature doesn't mean that they don't have the potential of having COVID.
Yeah.
Now, as I mentioned, with the SARS-1 pandemic, it was alleviated not because we came up with therapies or vaccine, but because we ardently adhered to preventative measures. So
Yeah.
wearing masks, keeping social distance, washing hands, those are the hallmark of prevention for the disorder. And so
Okay.
that has to be very, very strictly and ardently covered. Now,
Yes.
the other thing is that because we know vitamin D is protective, to make sure that individuals have an adequate amount of vitamin D, that helps their body to fight off the disorder and to minimize the severity of it, as well as the mortality associated with it. So
Okay.
we have recommended to nursing home residents that they make sure that they take a vitamin D supplement and make sure that they have adequate levels of vitamin D.
Okay.
There are
Okay,
actually
thank
some
you.
countries in the UK or in the EU that have gotten to the point in which they're thinking about mandating having people take vitamin D supplements because it's just that important.
Okay. Thank you so much.
I would also mention that at this time, there are at least 19 different clinical studies, those clinical trials that I mentioned, that are looking at proving how effective vitamin D is. And I and my associates are actually working in concert with the University of Illinois, Chicago to try to set up a similar study. That information is going to come out, but even before that information has come out, the data that we have discovered shows that there is a statistically significant improvement in those individuals that do not have vitamin D deficiencies versus those that do. So it's important.
When they say 1200 IU of vitamin D, and it's micrograms, it's 30 micrograms.
Right. Well, international units, that's one way of measuring it. The microgram is another way of measuring. International units is pretty standard jargon. And so I usually give suggestions as far as IUs because every vitamin D has an IU on the label. Some of them may have milligrams, some of them may not. So 1,000 to 2,000 a day. So 1,200 falls right into it. Mm-hmm.
Okay. 150% it says of the
Yep.
daily value.
Yep.
Okay.
The other thing, it's interesting to note that when they established those records, those recommendations for vitamin D, they really hadn't thought it out. So they were looking at bone density, and they were saying that if people have adequate bone density, then they have adequate vitamin D levels. And so they based all their recommendations on vitamin D levels. Now they found at that time that African American women had better bone density at lower vitamin D levels. And so they felt that African Americans needed less vitamin D. But the problem now is that that may be the case for bone, but it certainly is not the case for something else that has a completely different mechanism of action. So for the immune system, that doesn't hold. And so again, having those values, having that 1,000 to 2,000 daily is important. The other thing is that there's another form of vitamin D, which is kind of mega dose. It's a 50,000 international unit doses. For those individuals who are severely vitamin D deficient, or for nursing home residents who you want to get their vitamin D levels up in a relatively short period of time, taking 1,000 to 2,000 units a day is going to take many, many months. But taking these higher level, these mega doses, there were studies that showed that taking a mega dose 2 to 3 times a week could get your vitamin D level up to normal in a matter of 4 weeks or less.
Speaking of bone density, Fosamax versus that Prolia, or is there anything there?
You know, again, it's just different generations of the medication. I basically say that just look at the data, listen to your doctor, and just, you know, I always say, okay, you're suggesting this, why? Why is this not better? Or is this less, or what have you? But again, I would say listen to your physician. They're basically the same medications. It's just how they're manufactured in some little nuance that makes them a little different than the other product.
Thank you.
I have a question. If you said that vitamin D is fat soluble, so if you take megadoses of vitamin D, a megadose, will that harm you if it's a fat soluble, or should you just do the 1,000 to 2,000 IUs?
Right. No, that's a good
So
question.
how is that different?
Yeah, fat soluble, as I mentioned, vitamins like vitamin C, it's water soluble. So if you get too much, any excess is excreted through the urine. Fat soluble, they maintain a presence in the tissue, and so they can build up and cause side effects. So you want to make sure that you're only taking 1,000 to 2,000 micrograms for maintenance. Now, for those individuals who are low and need to get their vitamin D levels up quickly, they're the ones who are generally recommended to take the larger doses. So if you're taking a daily dose, then I'd say taking 4,000 international units a day is too much. Taking 1,000 to 2,000 units, international units a day, that should be adequate.
And what about that one pill, 10,000 milligrams a week? How do you feel about that?
There was actually a study that took a look at, and this is maintenance dose. Remember, getting your value from deficiency to normal is a different circumstance. But with regard to maintenance dose, they took a look at individuals that took high doses, the 10,000 plus units, versus the individuals that took the smaller daily doses. And they found out that the people that took the smaller daily doses actually did better than the ones that took the mega doses.
And if you buy a vitamin D that does not have the magnesium, do you need to buy a magnesium tablet also?
Right. Magnesium helps to modulate vitamin D release. And so making sure that you have an adequate amount of magnesium. Now, again, the circumstance with magnesium is you can get magnesium from your diet. But if you want to make sure, then taking a daily dose of magnesium certainly is not going to be harmful and could be beneficial.
Thank you. Excellent.
Quite welcome.
Magnesium. Mm-hmm. Magnesium in this, in the once at one a day,
Yep.
the magnesium is 24 micrograms and it's 24%.
Right.
So you need,
yeah, every multivitamin has magnesium in it.
that's not enough, is it?
You're probably, when you consider that plus your diet, it probably is sufficient.
Okay, thank you. Woo!
Well, folks, are there any other questions?
I want to know why and how we can get the word out to Black and brown people about vitamin D deficiency, because I lost my cousin, and I'm sure that he was a young man, and I'm sure he was vitamin D deficient. And I just I just need to know what we can do, how we can get the word out, because that would help so many people.
Absolutely. And that's what I'm trying to do. Certainly, I'm trying to, and it takes a while, unfortunately, to get a article published in a medical journal. But the other circumstance is how many ordinary people read these medical journals, and that's where the difficulty comes. So I'm trying to find any way I can to get this information out to as many people as possible. And Tony has actually been very helpful in connecting me with one of the people that works with the Cox Media Group. So hopefully we'll be able to present some information to the general public. But I would ask any of you that if you have any ideas or thoughts as to how I might be able to proliferate this information out to the general public, please, I'd be most grateful for that help, because as I said, we can wait and do nothing until something happens, but unfortunately, something happens in a short period of time, can happen in a short period of time. So we have to be proactive. And if you've got something that is easy to take, that is safe, that has been around for years, proven safe, that doesn't cost a lot of money and can easily be obtained, why not do it now? And that's especially for people who are in high risk groups, those individuals who have comorbidity, those people that are elderly, those people that live in nursing homes, and people of color. Those are the folks that really need it badly. And again, I just read a report that said the majority of young people that are dying from COVID are of Latino descent. And so, again, people of color. So it's something that's so important. And the scientific community has looked at this so much, but even with all the information that they have not discovered, they have not put the link between vitamin D deficiencies and the increased mortality in people of color.
I have a suggestion. I try to use Messenger to send this program to all my friends of color on Facebook, and I don't see anybody here. You know, I started a couple of days ago, sent them the link and everything, and I don't know if they just don't believe or what, but maybe something very short and simple, right to the point, that we can get out to people. Maybe all of us could try using the different means of communication, getting the information out to them, like Messenger, Twitter, Facebook, but it has to be very short, simple, and right to the point. Is that something you can provide us with?
That's
Doctor?
what I was about to say. I will take my article summary and I will break it down to a very digestible, very simple to understand information about what's going on. And I will send that to you, Tony, and anyone who wants that, we'd be happy to send out to them, and they can send the summary out to whoever they feel appropriate.
And I will put the, this is being recorded. This will go on Facebook, and I will provide the link of this if they want more detailed information using the link. Watch the video here. But if everybody on this program can text me or email me your email address, I will make sure you get a copy of Dr. Fletcher's summary. Thank you so much.
And also, Tony, if anyone has any further information or questions that they require, please feel free to give them. Well, I can give it to you now, but my email address is rlfletchermd@gmail.com. So again, that's rlfletchermd@gmail.
Thank you. Any other questions? Khadijah had to leave just a few minutes ago, and she wanted me to express her deepest thanks and she's really appreciative of your presentation, and thank everyone who attended this program. Zoom is pretty awesome.
It is.
You can get people from all over the country
That's right.
to watch a topic, and it doesn't take you any driving time or anything.
Right.
So hopefully, if you're interested in other programs, let me know. I'll be happy to include you on the Zoom programs. We have at least one or two every other week. Dr. Fletcher, thank you so much. God bless everyone.
My pleasure. And I also like to mention that, you know, if any of you have groups that you'd want to do a Zoom presentation, let me know. I'd be happy to do it. Thank you so very much. I appreciate your being here.
Thank you.
Thank you, Dr. Ron Fletcher. Thank you very much. I'm going out in the sunshine.
Me too.
Yeah, there you go.
Yeah.
Thank you.
We'll see
Thank
you
you.
around.
Awesome call.
Bye then.
Awesome presentation program. I
Thank
really
you.
like this one, Dr. Fletcher,
Thank you.
because it gave some really good information.
Great.
So vital.
Yeah.
Because it's over here in that corner. Doesn't change. They're seeing it jump up there and they're seeing it.